Today we're going to be discussing suicide assessment, treatment, and prevention. This is a very important topic because those of us who are going to continue in the mental health profession will for sure encounter suicide, at least in some form, over the course of our career. I thought this quote is very powerful because it explains a lot about why people want to end their lives. Did you really want to die? No one commits suicide because they want to die. Then why do they do it? Because they want to stop the pain. And that's the case for many people who engage in suicidal behavior and think about death, is that the pain becomes too overwhelming and they don't have adequate coping resources. I thought this quote by Friedrich Nietzsche was also very apropos. The thought of suicide is a great consolation. By means of it, one gets through many dark nights. So you will see many of the patients that you come in contact with will have had thoughts of death but may not have acted on them. That's known as suicidal ideation, which we'll be talking about momentarily. And for many people, suicide is a coping mechanism. Just knowing that it is out there and available to them should it get too bad kind of provides them with a sense of solace. And so while we as mental health clinicians might feel very nervous about somebody having these thoughts, to them these thoughts might actually be very helpful and a way that they know that they have some way out should it get too bad. So just to go over some terminology for our lecture today, suicide is defined as death caused by self-directed injurious behavior with the intent to die as a result of the behavior. So this means that somebody ends their life by themselves with the intent of ending their life. It's not an accident. And we used to say committed suicide, but the new terminology is died by suicide. So whenever somebody has passed away as a consequence of suicidal actions, they have now died by suicide. A suicide attempt is a non-fatal, self-directed, potentially injurious behavior with the intent to die because of the behavior. However, a suicide attempt might not result in injury. So someone might attempt to suffocate themselves with their pillow, which usually is not successful. So you would not necessarily view them as having any kind of harm gone to them, but that because they did something with the intent of dying, that would have been a suicide attempt, even if it was a non-lethal attempt. Potentially also going out in a car without a seatbelt on, thinking that you may die, that could be considered a suicide attempt, even though the result of the behavior is non-lethal. Suicidal ideation, on the other hand, refers to thinking about or considering or planning suicide. So these are the thoughts of suicide without engaging in any of the acts. When we talk about suicidal behavior, we encompass both the thoughts and the attempts in part of that. So why are we talking about suicide? So suicide, sadly, fortunately was on the decline here. You can see going into the 2000s. And since 2000, we have seen a sharp increase in the numbers of deaths by suicide. So we were kind of hovering around 12 per 1,000, and we are now almost back to, the total is, we were hovering around 10 per 1,000, and now we are kind of hovering closer to 14. And this varies by demographic in terms of race and ethnic identification, with non-Hispanic white individuals, particularly males, having the highest rate of death by suicide. And we're going to be talking about some high-risk populations momentarily. What is most concerning is that we are seeing very high rates of suicide and death by suicide among young people. So suicide is the second leading cause of death after accident for young people within the United States. And you can see that across the board, across all age groups, we are seeing increases in the last decade, especially those in their late teens and early 20s in terms of death by suicide. So this is something that we have really kind of put a call to action to really understand what is going on and why this is happening and what we can do to prevent it, because every death by suicide is a preventable death. So this is specifically looking at rates of suicide among young people between the ages of 15 and 19 by race and ethnicity. It's in 2017. So you can see across the board that males take their lives at higher rates than females do. The males are the blue lines, the females are the orange lines. But we can see there are specific that white males and indigenous people who are male identifying are at highest risk for engaging in suicidal behavior and consequently dying by that behavior. And if you think back to our lines across the board, we do see similar trends. What is kind of worrisome is that previously some of the other racial and ethnic groups had significantly lower rates of death by suicide, and we are seeing much higher rates among Black males and Hispanic males, as well as Asian males across the board. Now, these are percentage of individuals who are engaging in suicidal thoughts and actions. And so you can see again here, previously identifying as Black or being Black was a risk protective factor against suicide. And we are now seeing that Black individuals have some of the highest rates of attempted suicide. There, the orange bar here. And that while white males are dying at higher rates, we are seeing higher rates of attempts among Black males. So this is something that is very new within the last decade, and something that researchers are still working to understand. But something that when you're working with clients, especially justice-involved clients, that we want to take into account their racial ethnic background, some of the factors that they face, such as racism, oppression, and how that might relate to suicidal behavior. So I just want to review quickly some of the high-risk populations and risk factors for suicide. LGBTQ youth are at a significantly higher rate for engaging in suicidal behavior. 2 in 5 gay, lesbian, bisexual, and transgender individuals think of suicide often, and 1 in 3 have made a suicide attempt. They are almost at 3 times higher rate of making a suicide attempt than straight identified youth. So they're facing a lot of issues. One of the issues is that they don't have maybe accepting youths in the home, accepting parents or adults in the home that don't accept their sexual identity or their gender identity, and so they feel very disconnected. So you can see that on the left-hand side that we have significantly higher rates of suicide attempts for LGBTQ youth who do not have accepting adults in their life versus having at least one accepting adult in their life. So when you're thinking about this from a therapeutic intervention, working with the family and helping them support their child can be a significant protective factor. Also, housing instability. We see that because of the fact that they don't have accepting parents, many of LGBTQ youth may not have housing stability. They may choose to leave their home. And so those who do not have housing stability or they have housing instability, they've been homeless for periods of time, that's the orange as opposed to the yellow line, we see higher rates of suicidal thoughts, attempts, and having multiple suicide attempts as compared to youth who do not experience housing instability. Another population that we may encounter in the work that we do are veterans. The suicide rate among veterans has increased 150%. We are seeing there are 22 suicides per day. Individuals who are veterans die by suicide, 22 people per day. And at least a third of all veterans have considered suicide. So this is something that is very salient should you be working with veterans, especially those who have seen trauma in their tours. It's very common. We also see, in terms of suicide across the lifespan, older men have significantly higher rates of death by suicide than women, and generally across the board. This is because oftentimes, especially widowed older men, they don't have a lot of support. They're experiencing physical decline, and when they make a suicide attempt, they use very lethal means, and therefore they are more likely to die by suicide. We also see that justice-involved individuals are at higher risk for engaging in suicidal behavior, and this is especially salient for justice-involved young people. We see that those who are justice-involved youth compared to non-justice-involved youth have almost double the rate of ideation and attempts compared to non-justice involved youth. And this is really important when we're thinking about criminal justice system involvement, and this is the time to death by suicide. So this is the number of days after they've been arrested when the suicides have occurred. And so if you look here, the majority of the suicides are happening within 24 hours to 1 week of the arrest time. So this is a very high risk period. So this is often, and this is why we see more death by suicide in jails as opposed to prisons. So jails are where people are housed initially. Prisons is where they go for the long term. So in that first week after they've been arrested and are in jail is when they are most at risk for suicide. So this is when you have to do a very thorough suicide evaluation, and also when you have to determine whether somebody needs to be put on suicide watch and prevention measures need to be put in place. Another issue that is very salient is that youth who are being housed in adult prisons are twice as likely to commit or engage in suicide or die by suicide as opposed to those who are housed in juvenile facilities. So this is really important when we're thinking about kind of criminal justice system policy and charging youth as adults and putting them in adult facilities, because we are significantly increasing their risk of death by suicide. And finally, if you recall from a previous slide, Native American youth are 3 times die by suicide at 3 times that of the national average, which is wholly unacceptable. And so more resources need to be directed working to do suicide prevention and intervention among Native American youth. We do see that suicide is related to mental illness. It is estimated that of people who've been diagnosed with major depressive disorder, between 2 and 15% will die by suicide over the course of their lives. Those who have a diagnosis of bipolar disorder, it's 3 to 20%, and schizophrenia, 6 to 15%. So we are seeing high rates of death by suicide among people who have mood disorders and schizophrenia. We also see comorbidity with psychosis, anxiety disorders, and substance use disorders, which all increase the risk. We also see that people with personality disorders, particularly antisocial personality disorder and borderline personality disorder, are about 3 times more likely to die by suicide than those without those disorders. And about a quarter to a half of individuals who die by suicide also have a comorbid substance abuse problem or depressive disorder. One of the risk factors for suicide is the methods that are being used. And one of the reasons that we are seeing increases in death by suicide is some of the methods that are being used. If you look on the graph on the left, female rates of death by suicide have actually tripled, or almost tripled, over from 1999 to 2014. And that's because females are using suffocation, meaning generally hanging at a higher rate, which is a lethal means of death by suicide. And similarly, we are seeing increases in the use of guns as people have access to more weapons now. And when you shoot yourself, you're more likely to die by suicide. So you can see on the table on the right, this is specifically for males. And as you recall, males have a higher rate of death by suicide, especially young males, that more than half of them are using weapons or firearms to end their lives. And we talked about the older males. You'll see that 3/4 of older males are using a weapon. We also see that those who've experienced adverse childhood experiences, ACEs, so those are abuse, neglect, and household dysfunction, are at increased risk for making suicide attempts. You can see on the graph on the left that somebody who has none of those abuse, neglect, and dysfunction is, the percentage of those who attempt suicide is relatively low. And looking at that bright pink bar, those who have 4 of those, so physical, emotional, sexual abuse, physical neglect, or mental illness, are at significantly increased risk for making a suicide attempt. So that's something, again, that we need to evaluate when we're working with our clients, because those factors in their childhood may increase their risk for engaging in suicide. You also want to get a thorough family history because those who have a family member, a brother, sister, parent, grandparent who has died by suicide have twice the risk of dying by suicide themselves. So it's not 100% clear whether that is genetic or whether that is a learned behavior or coping strategy. Most of the research kind of points to a biopsychosocial model, so there's some interaction between mental, genetics and mental health transmission, but also kind of family circumstances and learning that is a possible coping strategy to explain why that risk exists. So when do you assess for suicide? Obviously, the first time that you meet somebody as part of your intake assessment, you want to make sure that you are asking them about their current and past suicidal thoughts or behaviors. And then when somebody begins treatment, especially if they've expressed some history or current suicidal ideation, you want to make sure that they are then being assessed at least on a weekly basis. You then want to assess periodically, even during high stress times. I generally give all my patients a BDI whenever I see them, just to kind of measure symptoms of depression. And one of the reasons that I like to do that is it has an item on there for suicide, and I give it to them before session, and then before session, and when they come into session, I glance over it, specifically looking for that item. I believe is item number 9, which is a suicide item, and I look to make sure that it is it is 0. If it is non-zero, then we discuss that, and I put that on the agenda to talk about that time. So how do you assess for suicide? The major ways of doing it are clinical interview, self-report, and then there are various different assessment instruments. However, many studies have basically found that the best way to assess for suicide is simply by asking somebody, are you thinking about hurting or killing yourself or ending your life? And that is often the best way to just ask somebody, and more often than not, they will tell you if they are experiencing that. So just ask them directly, normalize the behavior, let them know that thinking about suicide is not an uncommon behavior, especially for people who are experiencing difficulties like they are. And make sure that you don't ask in the negative form, like, so you're not really thinking about suicide, are you? Because then the person hears that you don't want to hear about it, and they're more likely to just say, no, I'm not thinking of suicide, even if they are. So here are some examples of language that you can use. You've told me a lot about your depressed feelings. Oftentimes people who have depression sometimes have thoughts of ending their life or thoughts about death. Have you been thinking about hurting yourself? Sometimes people think things would be easier if they're dead. Is this something that you've been thinking about? Are you thinking about doing something to hurt yourself? So just asking those questions, and doing it, as part of a clinical interview, people are quite likely to tell you if they're thinking those things or not. So if somebody is talking about, their thoughts of death, allow them to talk without interrupting them. Try to do that in a private place. Obviously, sometimes, especially when we're working with justice-involved populations, that can be difficult. But even if you can take them to the side and talk about those things, make sure you give yourself plenty of time. So I always ask about it at the beginning, because if they do endorse it, then you may have to kind of follow through and assess and do an intervention should there be a high risk of suicide. And if you're in doubt, if you ask and they kind of hedge or hesitate, keep asking, because there is something there, and they're just kind of hesitant to tell you. If they're giving you indications, even if they're not telling you, keep persisting. Always ask open-ended questions instead of yes or no questions. Convey acceptance and compassion, and that comes with the normalization of suicidal behavior, and reflect back to them. So some of those Rogerian techniques, that you're hearing their pain and some of the things that you're asking. Some of the key questions that you want to ask is, does your patient report command hallucinations telling them to hurt or kill themselves? So especially when we're working with individuals who have experienced some sort of psychosis, they can sometimes, even though they themselves don't want to end their lives, they can hear voices that are telling them to kill themselves, and they can act on those voices. So it's important to ascertain whether that's going on. Does the patient have a specific plan? Because having a plan increases their risk. Do they have the means to carry out the plan? So if they're telling you that they're going to kill themselves with a gun, do they have a gun in the house, which would then make that a high-risk situation? Do they have somebody to talk about their fears, their thoughts of suicide outside of you? Does anybody else know that they're feeling this way? Do they feel safe right now? Because if they do not feel safe and you ask them, you know, when they leave your office, number 6, what is the likelihood that you're going to do something to hurt themselves, and they cannot say that they will not, you then need to keep them there and potentially intervene and send them to the hospital. So what are you assessing when you're thinking about assessing for suicide? We want to look at our static risk factors. So those are our unchanging factors, so something that might put somebody at higher risk. So gender, we know that males are more likely to die by suicide, but females are 2 to 3 times more likely to make a suicide attempt. Their sexual orientation, which I've written down twice here, their gender identity. We know that LGBTQ individuals are at higher risk, especially youth. Race and ethnicity, as we talked about at the beginning, indigenous people, white males, and now Black males are especially at high risk for attempting suicide if they've had previous suicide attempts, because somebody who has made a previous attempt is more likely to make a future attempt, and whether they have a history of family suicidal behaviors. And again, that comes into play with that 2 times risk that we talked about earlier. So other risk factors are if they're experiencing pain, they have substance abuse problems, they tend to be more impulsive, because we see a lot of suicide attempts that are done impulsively. If they have made a recent suicide attempt, the period of 30 days following release from hospital is a particularly high risk period. So if they have made a previous suicide attempt, to figure out when it happened and how you can do and how close it is. Also, whether they've experienced a sudden loss or other negative event, because people can behave, respond to those things with potentially suicide as a way out. If they have a serious or chronic illness, because suicide might be a potential option for them if the pain is not going away. And again, when we talked about the ACEs, if they have a history of trauma or abuse, that increases their risk for suicide. Protective factors, so connection, feeling safe, having close and caring friends, being in a safe neighborhood, being, for young people especially, having academic achievement, feeling safe at school, and having access to health services. The risk factors we've largely addressed: physical illness or disability, losing a friend or family member to suicide, bullying, mental health problems, death of a family member or friend, access to means, relationship problems, and a history of previous suicide attempts. Some of the warning signs that we might be experiencing. So the warning signs are having a sense of hopelessness, feeling isolated or alone, being aggressive or irritable. Some people will turn the feelings of hopelessness inwards and feel depressed. Other people will turn those outwards and be more physically aggressive, having lethal means, as we talked about earlier, feeling like a burden to others, a drastic change in mood and behavior. And this can go in either direction, because sometimes when people who've been depressed for a long time make a decision to die by suicide, that can actually brighten their mood because they feel like their pain will be ending. Frequently talking about death. So the old adage that if they're talking about it, they're not likely to do it is not true. That means that they're thinking about it, they're making plans about it. So if they're talking about it, they're probably at increased risk. If they are engaging in self-harm behaviors, and even if they might be non-lethal, sometimes they can become lethal. Engaging in risky behaviors, so drinking more, engaging in unsafe sexual practices, driving without seatbelts on, that's an indication of passive suicide. Making funeral arrangements, giving things away, abusing substances more, making suicidal threats or gestures, and having a negative view of self. So all those things can be potential warning signs for suicide. So one of the things that you want to assess with suicidal ideation is the frequency, intensity, and duration. So the more frequent, the more intense, and the longer the duration of the thoughts, the increase the risk. You want to look at the plan. Do they have a specific method? Do they know when it's going to happen, and how detailed is that plan? This is the suicide intent scale. So this is when somebody has actually made a suicide attempt. or is thinking about suicide. So, like, was there isolation involved? What was the likelihood of intervention? Did they take precautions against discovery? Because all of those things suggest that they did not want somebody to intervene. Did they make any actions to go for help? Did they prepare for their death? What did they do to prepare for the attempt? Was there a suicide note left? Was there any communication of intent? What was the purpose of the attempt? Was it to get attention or to die? Were they expecting to die when they made their suicide attempt? Was their perception of the method's lethality? Did they think that by doing what they were going to be doing that they may end up dying? Objective view of the attempt suicide, seriousness, desire to live or die. The perception of rescuability, like did they think somebody could possibly intervene or would intervene, and the degree of premeditation. One of the more important things to assess for is access to means. Is it available, easily obtained, and potentially lethal? So do they have medications that they can use to overdose in the house? Is there a gun in the house? Is there something that they could use to hang themselves? So these are the suicide deaths by method in 2014. So again, half of it is by firearms, about 16% is suicide, about a quarter is suffocation, and that's death by hanging, and then we see 7% of kind of other. That's when people, drown, get in car accidents on purpose. Those who make precautions against discovery or put that into their planning stages are at increased risk, because if they're, telling people they're planning to do it when somebody is not around, when that they are lying about the time and the place, if they're things like that, that means that they do not want to be detected, and their intent is higher. You want to know what their reasons for dying are. Ask them directly and listen to what they are. You want to hear, is this more a sense of escape, or is this, is the pain too much? Is this a cry for attention? Do they feel like they're being neglected? So you want to know what that is, and that will also inform how you're going to proceed in treating the individual. You want to get them back in touch with their reasons for living. So figure out, when you want to ask their reasons for dying, you want to also ask for their reasons for living. Is there a pet? Is there a religion? Is there a family member, a child? All those things can help to kind of re-engage the individual. And even if that reason for living is very small, it might be enough to keep them alive. So, even if it's just, that they want to see their child graduate from high school, anything that can keep them alive for another day. And every day that they have that they're living is another day that you can intervene and help them. So some of the things that you want to assess for the protective factors. So hope for the future, self-efficacy, have they been able to solve problems in the past, their attachments to life, and again, assessing for any responsibility to children's, family, pets, their attachment to therapy. You can use, tell them that you would be devastated if something should happen to them. Talk about their social network. We know that people who have, engagement with others are less likely to die by suicide. Is there any social disapproval that's going on? So you want to assess for that. The belief that suicide is immoral. So if it's against their religious belief, that's a strong protective factor. Their commitment to live and their willingness to follow a safety plan, which we'll discuss a little bit later on. So once you've assessed for suicide and determined that there's a non-zero risk, you want to then look at intervention. So the main treatments that we use for suicidal behavior are cognitive behavioral therapy for suicide, CBT, which I'm going to be telling you a little bit about today, DBT, which we've talked about previously, where you're really focusing on that high-risk behavior and how to cope with it, and also how to deal with those emotions. We see the collaborative assessment and management of suicidality. It's the CAMS program. It's a more recent program that's been developed. It's kind of a holistic. It can be done within organizations, and you're looking at kind of assessment and treatment using some of the strategies of CBT and DBT. And then especially for youth, we see that multisystemic therapy, working with the individual, the youth, as well as their family and their community, can work to decrease suicidal behavior. So cognitive behavioral therapy, we've talked a lot about in this course, but cognitive behavioral therapy for suicide is slightly different in that you are only focused on the suicide. While all those things the other things here in the bullseye are going to come into play. What we're really focusing on in the intervention is decreasing the risk for suicide. So while we're going to be talking about depression and distortions and coping skills and all that stuff, the focus of that is all to decrease the risk for suicide. So conceptually, cognitive behavioral therapy views suicidal behavior as a problematic coping behavior, and that goes back to those quotes that I told you about at the beginning, that suicide is a way of coping with when the pain gets to be too much, a way out. And as I mentioned, kind of looking back at that bullseye, it's viewed as the primary problem rather than a symptom of a disorder. While we know that suicide can be a symptom of both borderline personality disorder, depression, we're not going to be focused on those treating depression or treating borderline personality disorder, because we need to make sure the person is alive. We can't treat depression if the person is no longer living. So that becomes the primary problem until the suicidal risk dissipates. And it's viewed as an adjunctive treatment in the sense that you want to work with other individuals as well, like psychiatric professionals and other professionals, so that you can decrease the risk. You also want to develop a case conceptualization so that you understand why the individual is resorting to suicide and how that can be used to guide your treatment. So similar to other CBT interventions that we've talked about, CBT for suicide involves engaging and establishing rapport with your client. Using kind of a strategy similar to DBT, dialectical behavior therapy, you're going to conduct a chain analysis of what happened leading up to the suicidal thoughts or the behaviors. And so you want to kind of establish what happened next, what were your thoughts, what was the behavior, and then what happened. And that's going to help us so that we know, kind of how this is developing, what are the thoughts and feelings and behaviors that are leading to this, but also where we can intervene in the future. Then we're going to work on the crux of the therapy is focused on implementing CBT strategies to deal with the thoughts and the behaviors that are putting the individual at risk for engaging in suicidal behavior. And then you conduct a relapse prevention task where you have them imagine themselves back in that time when they were feeling at risk, kind of like that behavior chain analysis. And then you have them visualize themselves using those coping strategies to have a different outcome. So it's generally a 10-session intervention. Obviously, like everything else we've discussed, it's flexible, but this is kind of the 10-session model, and depending on the needs that are happening for your client, it can be shorter or longer. So you want to engage them in treatment, have them tell their story, which is their, what led them to think about or engage in a suicidal act. You're going to be assessing risk on an ongoing basis, so every time you talk to your client, and you're going to develop a safety plan. So we know, as we've talked about, that about a third of the change in psychotherapy is due to that therapist rapport. So we have to make sure that we're maintaining, open body language, good eye contact, that we're engaging in active listening, that we're empathetic, and that we're using capsule summaries to really genuinely show that we're engaged in listening to what the person says. So having the patients tell their story, so after you've done your intake assessment and you understand, have them tell their story, what led up to their suicide attempt or their suicidal thoughts. And here, what you're doing is you're listening for those thoughts, feelings, behaviors, emotions, sensations, events as they go through that chain, in that time leading up to the suicidal behavior. And that's what we're going to be talking about in terms of what we can intervene. When the individual is not very clear, or if they have a hard time identifying these things, then you're going to ask more questions because you want it to be as detailed as possible. And this comes into the relapse prevention strategy at the end, where they want to visualize themselves back there and then using different techniques. So the goal of the telling of the story is to identify triggers. So is there certain event that happened? Were there certain thoughts? Were there certain feelings? You also want to identify places where the patient could intervene, because that's where you're going to focus the treatment on, identifying those triggers so that the patient can then use skills to decrease their risk. And then together you work on developing that chain analysis. You'll go through it together and then identify those places where there could have been a skill used or an alternate outcome had they used a skill. So this is kind of a sample behavior chain analysis. You're going through, you're identifying thoughts, behaviors, emotions, kind of starting with the prompting event and then going through um, what happened. So safety planning is very important. This is very different from a no suicide contract. We know that no suicide contracts do not work. There's been research on them, but a safety plan is what an individual can do in the case that they are experiencing, suicidal thoughts or behaviors. So you're going to identify their individual warning signs, which you got from their behavior chain analysis. You're going to identify coping strategies that they can use that you've been working on together. They will have a list of personal contacts if those coping strategies are not working, and then professional contacts should they feel that they are still at risk for engaging in suicidal behavior. And so once you develop that safety plan, you want to make sure that your client understands it, that they're willing to try it should they be experiencing suicidal thoughts and behaviors. Do they think it's going to help keep them safe? And how are they going to remember to use it? So today everybody keeps everything on their phone. I'm a big fan of having pieces of paper, but that might just be because I'm older now. But you want to make sure that they keep it someplace where they can easily access, that being on a phone, in a purse, on their fridge, so that they know where it is if they have it, and that they're willing to use it should they experience those kinds of thoughts. So this is a sample safety plan. When I notice the following signs, and then you're going to put the warning signs that leads to, what that leads to, then I plan to do the following. This is where you put in your coping strategies. If they have others around them, you can say when others notice the following signs, you would like them to, and so you try to engage other people in their surroundings to try to help them. They know that they're in serious trouble when I or others notice that, and then when they're in serious trouble, decide what they're going to do. So you want to work on that collaboratively, and that should be available to the client. Again, this is something that they can have on their phone, or it can be a piece of paper, or it can be something laminated, whatever works for the client and whatever might work to access them. So again, in those early sessions, you're developing your treatment goals. You're talking a little bit about the cognitive behavioral model and how you're going to use that to address their risk for suicide. And you're going to help them work and transform that hopelessness into hope. So you're going to tell them, that almost everybody who wants to, that suicide is preventable and that their feelings of hopelessness can be transformed into feelings of hope. I often like to tell the story of the individual who jumped off the Golden Gate Bridge. You can even show them the YouTube video, but there's one individual who jumped off the Golden Gate Bridge and survived, and he said that the minute that he jumped off that bridge, he realized that he wanted to live. And so he has spent the rest of his life kind of going around and talking to other people about, who've experienced suicidal thoughts, about, his story and how there is a better life out there if only you live to see it. So some of the strategies that you can use is targeting hopelessness using imagery. So you want to find images that give the person hope, that give them peace. You want to develop a list of reasons for living, and you want to add to that list, because as the person kind of comes out of their depression or their suicidal thoughts, there might be a brighter there. And again, this is something that they want to have access to, that they can write down. One of the things that I really like to do with clients, and especially people who are crafty, this can be really a fun exercise, is create a hope box. It can be an envelope, it can be a series of, it can be something on Pinterest, it can be virtual. Again, I like something tangible, but you have them bring in a box, you can decorate it together. It's this nice activity, especially if you're working with younger people. They can be very creative. It's a collaborative exercise, and you have them bring in things that give them hope, that make them feel good. You see in this hope box, there's a mug. I love my cup of tea in the morning. That is something that I cherish. And so having something like that, people bring in music that makes them feel good, letters from loved ones, psalms that they might find solace in, pictures of loved ones. There might be some self-soothing things. You can think of your DBT strategy. And then you'll work through kind of talking about the meaning behind each of those items and why that item gives them hope. And so you then, assign it as a homework assignment so that they then look at those items and think about the meaning behind each one, touch them when they're feeling down over the course of the week. And then you can add to that help box as necessary. You then work on reasons for living. There are various different sheets that you can use, but here, you have you can do this like visually. Again, you can make a collage. There's spirituality, there's people in your life, responsibilities, fear of what would happen if you die. So you can do this again visually, you can do this in written form, whatever works for your client, but you want to address this in treatment. And there are also visualizations and meditations for hope. So this is kind of along the lines of mindfulness, where you can actually look, do mindfulness exercises that end in hopeful imagery, and that have them practice this on a regular basis, because we know that doing regular meditations, regular visualizations can decrease depression and consequently suicide. You're also going to want to teach them problem-solving skills. So when problems come up in life, how can they address them? There's simple problem-solving worksheets, identifying the problem, generating alternatives, evaluating and deciding on a course of action, and then taking action and appraising the results. So this is something that you want to do in treatment. You want to identify problems. You want to brainstorm with them alternate solutions, have them decide on a course of action, practice that over the course of the week, and bring it back to treatment the next time you see them and discuss how that went. Should we do something different? And if so, go back to step 2. Or sometimes you even have to restart and go all the way back to step 1. But this is something that you want to teach them to do again on their own. You want to increase social activities, because social support is a protective factor against suicide. Make a list of people to call and their phone numbers, social supports, schedule social activities. Sometimes, especially when people are feeling depressed, they stop doing a lot of the things they love doing. So you want to make sure that you're finding things that they might be willing to do, assess their willingness to do them. Don't overplan somebody, but make sure that they have a list of things that are available and ways that they can access that. You also want to use some of those DBT strategies that we talked about, like the physical self-soothing, so things like exercise, meditation, distraction, and then sensory stuff like bath, fragrances, scrunchie, or there's those handheld balls that people sometimes use. Those can all be kind of helpful in coping with strong negative emotions and improving them. This is one of my favorite things to do, are these coping cards. So this is when somebody has negative cognitions. You put the thought on one side, and then on the other side you kind of put the rational response. They can carry them around, and again, I do this in hard copy, and today everybody does things on their phone, so however the person wants to do it, but that they can reference those rational beliefs, or those ways of coping in difficult times. So it's really a way for them to have those skills available to them when they need them. We want them to read them regularly, and so that eventually those thoughts become accessible to them on their own. But you also want to include emergency numbers should those cards not be sufficient that they're there. Here's just a sample of some of the coping cards, and these are kind of things that you're going to be working on in the middle sections. So if the automatic thought might be, there's no way out of this, the response on the coping card could be, things are really tough right now, but that doesn't mean there's no way out. I've been through a lot of hard times before, and I've always made it through. I know I can talk to my mother about helping out with the rent, and if that doesn't work, I can take some odd jobs. The automatic thought, I'm a burden. These are my family. They'll do anything for me. They don't think I'm a burden. If someone I loved was suffering, I wouldn't think they were a burden. So that goes back to that, what would you tell a friend? And so that can also be helpful. And then the final sections, you're working on kind of the relapse prevention task, where they're going through the initial suicidal crisis that brought them to treatment, or that they identified when you saw them at the beginning, and then they're using those coping strategies that you've worked on in the middle sessions to kind of get them to a different place. You then, if this is going to be the end of your treatment intervention, because oftentimes we don't have a lot of sessions with our clients, you want to make sure that you're not that you're terminating appropriately. In some cases, if they need additional sessions, if that's applicable, you can do them. You want to schedule booster sessions, kind of check in on them, especially the last sessions. You might want to space them out if they're doing better. And then, after the 10th session, you can then schedule to see them at some point in the future, just to check on where they are, how they've been using their coping strategies. If they anticipate any problems, then you can work on solving those together. And then remember, that as long as you are alive, there is always hope. Thank you, and I hope that you enjoyed the lecture and that I have offered you some strategies to work and assess your clients who might be experiencing suicidal ideation.